Hi everyone, this is Emily Bach presenting on Group B Strep, otherwise known as GBS. Group B Strep is a gram-positive beta hemolytic bacterium. It's typically a normal bacteria found in the vagina and GI tract. It very rarely can result in maternal infections, but can cause severe neonatal infections. This is because there's a risk of vertical transmission during birth, where the mom's naturally found bacteria is transmitted to the baby. Risk factors for GBS include having the GBS colonization, being under 37 weeks gestation, having prolonged rupture of membranes, which is 18 plus hours, having an intra-amniotic infection, being of young maternal age, and being of African ethnicity. Epidemiology statistics. So the prevalence, 10 to 30% of women are GBS colonizers. On average, it's 1 in 4 pregnant women are positive for GBS. The incidence, maternal invasive disease is about 0.12 per every 1,000 live births, which is very, very small. And that's in regards to severe maternal infections, not when they're asymptomatic carriers. When transmitted, there's a 1 to 2% risk of GBS disease in the neonate. And then on average in the United States, there's 930 babies each year born with early onset GBS disease and 1,050 babies each year with late onset. On average, 4 to 6% of all infants with GBS disease will die, and if they're preterm, their mortality rate increases to 20 to 30%. Transmission, 50%, there's a risk of 50% transmission from mom to infant without antibiotics. Without prophylactic antibiotics, it's about a 1 in 200 risk. And then with prophylactic antibiotics, the risk decreases from 1 to 4,000. Maternal, perinatal, and fetal risk. So maternal risk, typically women are asymptomatic and they really don't have any symptoms at all and really no risk. Once in a while, they'll get asymptomatic bacteriuria. That's the most common maternal risk, UTI, pneumonia, or bacteremia. For perinatal risk, it includes upper genital infections, which is an intra-amniotic infection, or chorioamnionitis, post-C-section wound infection, postpartum endometritis, and stillbirth. For fetal risk, their early onset risk would be pneumonia, sepsis, and meningitis, while the late onset is typically just meningitis. These can lead to deafness and developmental disabilities in the child as they get older. Patient presentation. So with maternal, they're asymptomatic, so no symptoms. With infants, early onset consists of the first 24 hours of life to the first 7 days after birth. So it's really the first week of life that they have symptoms and they're sick, or when they begin to get sick. Late onset is after 1 week post-birth to 3 months of age. So infants will have lack of energy, lethargy, they'll be irritable, poor feeding, high fever, difficulty breathing, and even like a blue skin tone. With bacteremia and sepsis, they'll have a fever, chills, low alertness. And then with pneumonia, the infant will also have fevers, chills, cough, rapid respirations, and difficulty breathing. Differential diagnoses. So with the neonate and mom, they're both the same diagnoses, it's just they're caused by a different type of bacteria. So the neonate will have bacterial pneumonia, meningitis, or sepsis, but they'll be caused by a different type of bacteria or a different, like a viral infection. With the mom, she'll still have either like a UTI or endometritis or a wound infection, but again, it will be caused by a different type of microorganism or pathogen. Diagnostics. So universal screening for GBS is now recommended for all women between 35 and 37 weeks gestation. It's a single swab, starts in the lower vagina and then in the rectum. It's inserted through the anal sphincter. A speculum should not be used, and this swab should not be a cervical swab, perirectal swab, or perineal swab. The patients also have the option to swab themselves if they're more comfortable with that. The provider can instruct them on what to do, and it's just like a kit, and like in the picture I have right here, and they can just do it by themselves and turn it in. Treatment plan. So for pharmacological, it's IV antibiotics are recommended. The most effective antibiotic is penicillin Q4 hours. Ampicillin Q4 hours can also be used, as well as cefazolin Q8 hours or vancomycin Q12 hours. If they have an allergy, then IV clindamycin every 8 hours is recommended. The antibiotic should be administered at least 4 hours prior to birth. It has to be when the woman is in labor. It can't be before, and it has to be IV antibiotics. It cannot be oral antibiotics. There are no alternatives other than the different types of antibiotics I listed above. You can't eradicate the bacteria with chlorhexidine, garlic, or probiotics. That's not recommended. Women need IV antibiotics if they are positive for a GBS swab, have a prior history of an infant with GBS disease, GBS bacteriuria during this pregnancy, no swab or a swab that is 5 weeks or older, prolonged rupture of membrane. So again, their membranes ruptured 18 plus hours ago, or they have an intrapartum fever. Treatment plan education. So the woman should be educated that GBS is a normal bacteria found in the body and the skin. It's not a sexually transmitted infection. Antibiotics are not effective prior to labor. They have to be administered during labor, and it has to be IV antibiotics, not oral. They should also be educated on the risks of not getting tested and or not receiving the treatment if they are positive. They still need to be swabbed again, even if they have a prior history of being GBS positive in other pregnancies or have a planned C-section. If they are positive and have a planned C-section and they don't, and their water doesn't end up breaking, their membranes don't end up rupturing, they don't need IV antibiotics. And then the IV antibiotics reduce early onset GBS, but not late onset. And then as far as non-pharmacological follow-up and fetal well-being tests, there aren't any specifics recommended. It's just routine care. Of course, things would be more complicated, and the mom and baby would both require more intensive care and more intensive follow-up if they did develop these complications. But typically, the woman and baby both do fine if the mother is positive and she receives antibiotics in labor. Here are my references for the sources I used to complete this presentation. Thank you so much for watching my presentation. I hope you enjoyed it and you learned something.